What's up, folks? I'm Dr. Zed, back with another video from our New York office, so I'll do my best to keep the background noise to minimum. The board-style question we're reviewing today requires us to know how to diagnose a subtype of pneumonia and its most likely cause. Click on the question link in the top corner so you can follow along. And actually, I'd really appreciate if you click on any of the links you find useful, as it helps in determining if these videos are beneficial to you. I'd even recommend pausing here and first try to answer the question. Once you've done that, let's start by determining what we should do by reading the lead-in. Which of the following is the most likely causal organism? Okay, we need to have a hypothesis of the diagnosis. Let's see if the diagnostic findings, an X-ray, the chest ray is shown, can help us. In the X-ray, we can see there are bilateral opacities that are predominantly distributed in the upper lobes and include linear and nodular infiltrates, as well as some confluency. While this finding is still somewhat broad, what are some differentials we should be considering? Definitely infectious, including atypical pneumonia or tuberculosis, some pneumoconioses like silicosis, or possibly other inflammatory conditions like sarcoidosis. Let's start reading from the top to narrow down our diagnosis. A 39-year-old woman comes to the physician because of a fever, nausea, and a non-productive cough for 7 days. Okay, with this combination, I'm already leaning towards an infectious cause. And the hallmark symptom of non-productive cough, especially in the test question, is making me think immediately of atypical pneumonia, sometimes called walking pneumonia, because patients still walk about and conduct everyday activities rather than stay at home and rest, which is more typical in typical pneumonia. So, reading on. During this period, she's had headaches, generalized fatigue, and muscle and joint pain. She's also had increased shortness of breath for 2 days. Okay, the constitutional symptoms and dyspnea are also aligned with our hypothesis, and to save time, I'm going to jump to the vitals, examination, and labs to look for more concrete findings. Her temperature is 38.1 degrees Fahrenheit, so low-grade fever, which also fits atypical pneumonia. Let's skip now to the lungs are clear to auscultation. This is also consistent with atypical pneumonia. There are multiple skin lesions with a blue livid center, pale intermediate zone, and a dark red peripheral rim on the upper and lower extremities. Alright, this is a very specific finding. The question writers only put such specific info in a vignette if it's a strong pertinent positive for the correct answer. You can learn more about pertinent positives and negatives in this question walkthrough. To me, this sounds very much like erythema multiforme. As for labs, I'm mainly interested in a few things. Inflammatory findings like leukocytes or inflammatory markers like CRP or procalcitonin, and possibly hemoglobin and sodium. Why hemoglobin? Hemolytic anemia is associated with Mycoplasma pneumoniae, the most common cause of atypical pneumonia. But more on that later. And why sodium? Right, because another cause of atypical pneumonia, Legionella pneumophila, often causes hyponatremia. So these readings may come in handy ruling a pathogen in or out. Alright, leukocytes are 11,100 cubic millimeter, so still normal. But this is not unusual for atypical pneumonia. And both hemoglobin and sodium are normal. With all the supporting findings, I feel quite confident in going with atypical pneumonia as the most likely diagnosis. But before we proceed to answer the question, I'd like to briefly consider why not typical pneumonia? Well, many of the clinical features are, of course, different from atypical and include high fever and shaking chills, productive cough with purulent sputum, decreased breath sounds and crackles on examination, and on X-ray, lobar consolidation and alveolar patterns. Also, the pathogens are typically extracellular bacteria rather than intracellular pathogens, common in atypical. Atypical, I got a joke for you. What? Why can't you hear a patient with pneumonia urinate?
I don't know.
Because the P is silent. You can read more about these important differences in the Pneumonia AMBOSS article. So with that in mind, what are the top 3 bacteria that cause this condition? We already got a hint with intracellular. That's right. Mycoplasma pneumoniae, which we mentioned, is most common, especially in individuals younger than 40. Chlamydophila pneumoniae and Legionella pneumophila. There are, of course, several other causes, including chlamydia psittaci, transfer from birds, Q fever due to Coxiella burnetii, transfer from livestock, and viruses, which are all less common. To help you remember bacterial causes, remember the mnemonic, Atypically, legions of clams mine the P's and Q's. With that in mind, let's try to answer the question. We see that both Mycoplasma and Legionella are possible options. So how do we decide between the two? Well, everything here fits Mycoplasma, so that passes with flying colors as the most likely. Now, what about Legionella? While the presenting symptoms could fit, Legionella is an exception regarding fever, since it often causes temperatures greater than 39 degrees Celsius or 102.2 degrees Fahrenheit. It's also associated with exposure to contaminated water, such as at an air-conditioned resort, cruise ship, or a hospital, and is often accompanied by diarrhea as well as hyponatremia and its manifestations like confusion. On your exam, a question about Legionella, which you're likely to get, will give you a combination of these supporting findings. In addition, chest x-ray findings are variable, but often show patchy unilateral and lobar infiltrates that progress to consolidation rather than a diffuse interstitial infiltrate. Lastly, Legionella pneumonia is not associated with erythema multiforme. With that explanation, Mycoplasma pneumoniae is the most likely cause. And now, most importantly, what's Mycoplasma's favorite piece of art? Pneumonia Lisa. Let's briefly skim over the other options to see what high yield concepts we can reinforce. Klebsiella pneumoniae causes hospital-acquired pneumonia, aspiration pneumonia, or less commonly, community-acquired typical pneumonia in older men, especially those with diabetes, chronic lung disease, or alcohol use disorder. It would usually manifest with high fever and productive cough with thick and bloody sputum, classically described as currant jelly. An X-ray would typically show consolidation in an upper lobe with air bronchograms and possibly bulging of an adjacent interlobar fissure. Streptococcus pneumoniae is the most common cause of community-acquired typical pneumonia, and we already covered why this is unlikely. Haemophilus influenzae also causes typical pneumonia and more commonly affects children. Staphylococcus aureus is a common cause of hospital-acquired pneumonia and often develops as a superinfection in patients with influenza pneumonia. Although Staph aureus pneumonia can be associated with interstitial or patchy infiltrates in chest x-ray, this diagnosis is unlikely because it usually occurs in the elderly or patients with immunodeficiency, and this patient doesn't have a history of recent hospital admission. With the explanation behind us, let's consider what other questions could we get for this topic. The question writers could have swapped Mycoplasma out for Pneumophila pneumoniae, or they might have added a history of owning a parrot or other bird to make Chlamydia psittaci a likely cause. The same goes for Coxiella burnetii in dealing with livestock. They might have just asked for the diagnosis of atypical pneumonia. Although more likely to appear in step 1, perhaps they would have changed the options to fitting microbiological findings, such as Mycoplasma growing on eaten agar or colorless gram staining due to lacking a cell wall. They might have mentioned or asked about additional associations of Mycoplasma pneumoniae, such as the formation of cold agglutinins, IgM, or resulting subclinical hemolytic anemia, although this patient did have normal hemoglobin. Lastly, they could have asked for the best antibiotic therapy, which would have been macrolides, fluoroquinolones, or tetracyclines. You can review all this info in the AMBOSS library. To summarize, the key concepts of this question are: diagnose atypical pneumonia based on common findings of non-productive cough, dyspnea, low-grade fever, unremarkable auscultation of labs, and interstitial bilateral infiltrates on X-ray. Know the causes of atypical pneumonia and their specific associations, including Mycoplasma pneumoniae as the most common, which can also cause erythema multiforme. And that's it for this question. If you found this video helpful, I'd really appreciate a thumbs up, comment, or subscribe so I know to keep making them. Also, check out any of the links to the question, articles, or social media channels in the description for even more content. As always, remember that hard work pays off, so keep up the studying. You've got this. Beep beep. Honk. Woo. How much background noise could we get in one recording? Jeez.